for this week, something that you might have watched or read that you want clarified. There's a lot of information before we get started. I always want to give you an opportunity. Okay. So, this week we're talking about the antepartum. In other words, the pregnancy itself. What we do when we are admitting a patient who's pregnant to the prenatal clinic. And we're talking about the physiological changes in mom during pregnancy. What's going on? How do we measure it? And then we also touch base on fetal anatomy and physiology, fetal development. So it's going to be hard to cover all of it. So I highly recommend that you watch the pre-recorded lecture because I cover everything, and that you also look at Canvas and find those notes that I give you in the announcement that you can download and use to study by as you going through your book or listening to a lecture, a pre-recorded lecture, or however you want to use them. I think this really helps. Okay. And it helps you prepare for your quizzes. Anything you want to ask me before we get started? I want you to do really well. Remember, you need to be on camera with one of your devices, not necessarily both of them, just one. Okay. All right. It looks like we have some people missing, or do we? Let's see. We have 25. It's hard to tell because some of you are on 2 devices. All right. Who's iPhone 8? Anybody know?
Diana Morera.
Okay. Thank you, Diana.
Thank you.
All right. I'll do that. And Rachel, it's hard to believe this is only the second week to me.
Right.
It seems like it should be like week 4. I don't know. The last 2 weeks have really gone slow, I guess. That's the way of looking at it. But anyway. All right. Is everybody ready to take their quiz? So get on Canvas, and I will get on Canvas and get your access code. Remember, this is a timed quiz. Don't rush. You have 15 minutes. It's plenty of time. But I don't want you just to poke around either. All right. Oops, not what I wanted. Let's see here. So access code. The access code to your quiz. Does everybody get their quiz okay? It's OB. Uppercase O, uppercase B.
Yeah.
Uppercase O, uppercase B. So now you may start your quiz. Please remain silent. Okay.
That's it. Just OB?
Yep.
Okay.
Okay, Angela, your OB access, I'm sorry, your quiz number 1, access is OB, uppercase. if anybody wants to go get something to drink, go to the restroom or something before we get started, we still have 2 students that are taking their quiz. You can get up and go. Okay, everybody. So let's look at the quiz. All right. I want to look at it and go over it with you. So, risk factors when we do a history on our new patient that's pregnant, if they are obese, or if they have diabetes, or if they have a history of high blood pressure or hypertension, or sometimes autoimmune diseases, they're considered high risk. Adolescents, or a woman that's older, 35 years and above, they are at a higher risk for having problems during pregnancy or having problems with normal fetal development. Okay. And then reasons that some patients are not able to get good prenatal care, or get consistent early prenatal care, or what we talked about last week, they can't get there. They don't have any transportation, or they don't have enough money for gas. They're working and they can't get away from their job, or they're caring for younger children and it's just a burden to get there. Maybe they don't understand that they need to go. Language discrepancies, things like that. We do urine testing. You can do it at home as well, home test kits for a hormone that's found in a woman's urine when she's pregnant as early as 10 days after conception or 10 days after intercourse. It's called human chorionic gonadotropin. Okay, it's just one of the normal hormones that helps progress the pregnancy. And we're going to talk about the implantation of the zygote, not a zygote, it's a blastocyst. After fertilization occurs, it travels through the fallopian tube, makes its way into the uterus, and then finds a nice soft bed of lots of blood vessels to connect to, for the placenta to develop against, and for the baby to grow. So implantation inside the uterine, in the endometrium. SBAR, situation background assessment and recommendation. If you don't know how to perform a certain patient care procedure, you want to make sure you're looking at the facility patient or procedures and policies. Yes, you can also ask someone else, but you want to make sure you're following policy so you're not held accountable if something goes wrong. Racial disparity in maternal care. Racial disparity in maternal mortality, infant mortality. The women of color have a higher risk. Remember that, because when you're out there working, you want to be very astute about what are some common causes of high-risk patients. Why? Social media. It can be good. It can be disadvantageous for our own privacy or our patients' privacy. You are not to talk about patients on an elevator, in another patient room, with family and friends, and certainly not on TikTok or Facebook, Instagram, or whatever social media you use. You're not to talk about other patients. It's just a real gray area because you don't want to use a name and you don't want to use a birth date or anything like that. The morphine we're going to give our patient, she needs 4 milligrams, and there's 10 milligrams per ml. And the answer was 0.4 ml. Values and beliefs. Our patients have values, traditions, beliefs, their culture, and the things that their traditions, and they make their healthcare decisions based on that. That's the way they were raised, and what geographic area they lived in, what their family environment was when they were growing up. So values and beliefs. That probably was a hard question for you to answer. I'm looking at this. Was there a select all that apply? I might have to go through this. Oh yeah, there was one. The only one that had a select all that apply was the one about barriers of getting good prenatal care. And there was only one that wasn't right, and that was job commitments. Okay. Actually, job commitments was right. I'm sorry. all of them were right. I'm thinking, wait a minute. All of them were right. So if you didn't choose all of them, that's why you didn't get a full point. Okay, so if you got 8.6 or 8.4, it's because you didn't choose all of those. So job commitment, no transportation, childcare responsibilities, deficient knowledge related to early and frequent prenatal care, and then inability to pay.
Professor Zeller.
Yes.
So if job commitment wasn't one, we'll get like a half a point for it. Well, I mean, that point was taken off. That 1 point.
The job, so all of the answers were correct. I'm sorry I confused you. All of them were correct. So if you did not choose all of them, it depends. There were 5 answers. 1, 2, 3, 4, 5. So you would get less than 1 based on which ones you didn't choose. Does that make sense? So you got a partial point. You got partial points. We didn't used to do that.
No, it made sense. I just maybe I just looked too deep in that particular answer.
Okay. Well, we can go over it, but I can't go over each quiz with you individually as a group like this. Okay.
That's fine.
Okay.
Yes, ma'am.
So if you want after class, if any of you want to
I'll
meet
see
with
you
me.
Thursday anyway.
Okay. Which is tomorrow, right?
Yep.
Or
10 o'clock.
Yeah. Okay. So, what was I gonna say? Yeah. So if you didn't get an 8 or better on this quiz, I do want to go over the quiz with you. Okay. But if you did better than that and you're okay and you know what you missed, then just keep it in mind. All right. So let me pull this up. This week, I want to go over the announcements so that you are getting used to your weekly announcements. I gave you your salient concepts or your notes. There's 3 pages of notes, and then there's an extra PowerPoint there. Chapters 6 through 10 is the content we're talking about this week. And then I've got 3 videos here. 2 of them are mine that I did for you. Those are the pre-recorded ones. The third one is just a great video on placental and fetal circulation. It's really good. So the pearl this week, in other words, keep in mind that in order for the fetus to receive nutrition, get rid of waste products, have more than enough oxygen available, mom's blood pressure has to be normal, or at least not real high and not real low. And the volume of her blood, same thing. We want all that blood that's supposed to be in the uterus available for that placenta. Okay. So we are going to talk about placental perfusion again today. Okay. We're going to talk about how we define a pregnancy, how we measure it. What's the due date? What are some early signs? What would we see? What would we hear from the patient? And then we're going to just talk about a few of the system changes, cardiovascular in particular, during pregnancy. And then there's all my regular PowerPoints down below here that I provide for you. So the OB calculations, if I sent you feedback information, please correct what you got wrong. And if you don't know how to do it, then we do need to go over it together. You're going to have 5 OB math questions on every exam that you take. So you need to know how to do your math. That's one reason. Another reason is because you're going to be needing to calculate things when you're working. If you didn't get your calculations done last week, please get them done this week. But know that you will get a grade deduction, but you still need to do them. Okay. So this week you have a discussion, your very first discussion question. Now, in the course cafe, which is in the student modules, Let me pop over there. And the modules. If you go down to course welcome module before you get into the weeks, at the bottom is the course cafe. In the course cafe, as a reminder, I have, let's see, the article called Innovations in Preconception Care, Optimizing Health. You can use that article or you can look for one on your own. Okay. But I just gave you this one and I gave you those other sites that you can use. I also posted an article in for week 3 because you have another discussion assignment in week 3, I believe. So there's another one there that you can look at. Okay. Okay, so another thing, at the end of this week, because you have an exam in week 4, we do review sessions. Each instructor has a review session that it's optional, but it's certainly recommended that you can attend. We record it and each instructor will do something different to help you get ready for the exam. So the idea is that you bring questions or areas that you just don't know and don't understand with you when you go to the review. So you can ask questions. So we'll do that during week 3. So at the end of this week, we'll send out a schedule of who's having their session when. Okay. I didn't want to forget that. So you also have intimate partner vibes, your very first sim chart this week. Remember, the grade of your sim chart is actually the quiz grade. The more you read the chart and document as it instructs you to do, the higher your grade tends to be. I will be looking at these very carefully this term because students have told me that there have been some errors. And so I really need to look at it carefully. So if you get a grade that's not what you thought you got on any particular sim chart, let me know. Okay. And then at the bottom, there's just extra um, videos I have for you that, for GTPAL, and we're talking about that today. There's a practice website, and there's just some great videos just to kind of cement what you're learning. And, the more you repeat it and review it, wait a day or so, and then watch some videos and study your notes. And then that helps to retain it much better. Okay.
Is the concepts that you put on here the notes? Because I know in the first week it said notes, but
yeah, I know. Yes, the salient concepts.
okay.
It is the same thing as notes to read while you read the book. Yeah, notes to use while you read the book. It's the same thing. Okay. All right. So we're going to do something a little different today because there are 20. Is everybody on just one device now? I mean, it doesn't really matter. But the thing is, I'm going to put you in breakout rooms. So you need to only be on one device, a device with a camera. So shut down the other device or get out of Zoom on the other device.
I'm on 2 because I can't hear you on mine. I think it's the Verizon thing. I don't know.
Let me see. Is there a Verizon one you said?
No, this Whitney. I'm on 2 devices. I can hear you off my phone.
I see that. So which one is your camera you'll need
My
both
iPad.
of them. Okay, I'll just put both of them in your room. Okay. Anybody else have to be on 2 devices? Okay. You'll probably get that figured out, Whitney. Okay, so let me pull up what we're going to do today. So I'm going to ask I'm going to ask Zoom to move you automatically, whoever you are, to a room. And so room 1, so what you might want to do then is take your phone and take a picture of this or do a screenshot of it so you know what you're doing in which room. So if you're moved to room 4, you know what you should be doing. Okay? So go ahead and take pictures of this. So if you're in room 1, and I'm going to come to each room just to remind you, you're going to teach the class the Nagel's rule and the probable signs of pregnancy. Room 2, you're going to describe the blood flow through the placenta to the fetus. Excuse me. Room 3, you're going to explain what MSAFP is, the test itself, and what do we do if the results are abnormal? What's one thing we do for sure, and maybe a second. Room 4, what is carrier screening? And what do we screen for during pregnancy? Which ones do we do? Describe and then room 5 would be describing the physiology of supine hypotension and what signs the nurse should anticipate if that's what's occurring. Okay, so what I want you to do is pick out a spokesperson, or all of you can share what you want to share in that group. And I want you to work as a team. Now, if you get in a room and you have no idea what it is, like blood flow through the placenta, then you're just going to have to pull up the PowerPoint or pull up your book and look for it. Okay? So you can pull up one of the PowerPoints for this week. It should be there, or your notes that you downloaded. Okay? So anybody have a question? I'll give you 15, 20 minutes to work on it. Okay. And then we'll meet back together and each group will share and I will fill in and help you understand and expand on what you share unless you share everything that needs to be shared. Okay. Most students like doing this because it helps them work together and that nobody is in the spotlight. Okay. Any questions? Okay. Let me go ahead and do your breakout rooms. And we're going to do 5 of them since there's quite a few of us in here. And automatic. And what will happen, Whitney, I'll move you from one room to another. It's going to be kind of odd, but I'll do it. Okay. Let's see. Whitney Bell is there in room 2. And in room 5, I'm going to move room 5. Okay, move to room 2. Okay, now Whitney, you're in room 2. All right, so get ready. It should look for your invitation, okay, and then join the room. Sway, you're in room 5. Did you get your invitation? Okay, good. Addison, you're in room 1. Addison? Addison, I put you in room 5. Do you see your invitation?
I got one for 1 and then I clicked join and then it kind of just knocked me out. So I haven't gotten room 5 yet.
Okay. I'll put you back in room 1, okay?
Okay.
And watch for the invitation.
Okay, I got it.
Okay, great.
I'm sorry, I had to leave because my audio wasn't working. I'm in room 1. Can you add me back to that room?
I will.
Thank you.
Okay, let's get started again, everybody. Okay.
I would have hauled ass out the back door.
All right. So physiological anemia. So one change that occurs in the cardiovascular system during pregnancy is the growth in the volume of plasma, so much more than the amount of red blood cells. Now, she will produce extra red blood cells. Those red blood cells are going to enlarge a little bit during pregnancy. So so the growth in the volume of the plasma actually dilutes out the red blood cells. So it's called dilutional anemia. If you take a specimen of blood and look under the microscope, or you shake it up, the red blood cells are farther apart. It looks like she's anemic. because of the extra plasma volume. The total blood volume increases 50% during pregnancy, and that's to allow more than enough blood to perfuse the uterus and provide good blood flow to the placenta, and thereby good oxygenation and nutrition for our baby. Okay. Also in pregnancy, platelets drop just a little bit, but they're also a little bit larger. There are certain factors in our blood that are circulating that help to clot the blood. Some of the factors, along with the fibrinogen, are elevated during pregnancy. This allows for less blood loss during delivery. Iron usually drops a little bit. Some women are a little anemic because of iron, so we will have them take over-the-counter iron or prescribe it for them. So that's one increase in cardiovascular system. Who knows what other cardiovascular changes occur during pregnancy?
Doesn't the heart get a little bit bigger?
The heart, yes, it does enlarge a little bit. Yeah. Yeah. And why do you think that is?
To
More blood
provide
flow.
more blood flow, oxygen to the body and the fetus.
It has to work harder. So we've got you'll learn about stroke volume. In other words, the amount of blood that is pumped away from the heart with each systolic pump. Okay. Every time the heart beats, it shoots out blood to perfuse the peripheral tissues and cells. So it's working harder, more blood, and a little bit faster rate. So the heart rate goes up during pregnancy. You might see some tachycardia if she's exerting energy. Her heart rate might go over 100. It's not that uncommon. Okay, so she's got more blood volume, a little anemic during pregnancy, and if we have to treat it, we will. The heart rate goes up during pregnancy. Other changes are increased white blood cells. Increased white blood cells. She has a little leukocytosis. Even in her urine, you'll see more leukocytes. It doesn't mean she has an infection. It just means that she is pregnant. Okay. All right. Let's learn how to define pregnancy, or let's get a history from a new patient that we just admitted to the clinic. So we want to categorize her obstetric history. We're going to get her family medical history. We're going to get her personal medical and surgical history. We're going to ask about genetic history and all of those things and do our screening. And then we're going to ask her, have you ever been pregnant before? Tell me about your pregnancies. Okay. So we call this gravidity and parity. Okay, gravidity and parity. So gravidity refers to a pregnancy. Term delivery refers to a baby that is at least 37 weeks when it is delivered. A preterm baby is a baby that's delivered before 37 weeks, but after 20 weeks. So between 20 and 37. Or 36 weeks and 6 days. We measure our pregnancies in weeks because there's always 7 days in a week. But months, there's a couple extra days in some of them. So there, 1 or 2 days in a pregnancy can make a difference. So we measure it by weeks. Abortions are pregnancies that are delivered before 20 weeks. Whether it is a miscarriage or a spontaneous abortion or a termination or surgical medical abortion. we refer to all of those pregnancies that did not survive to the 20th week as abortions. Okay, and then the last column is the total number of babies that she has delivered over her lifetime that survived, that were alive when they were born. Okay, so let's take an example. We're going to categorize this woman's pregnancy or her history, obstetric history. She said she delivered a stillbirth. In other words, a baby was not alive when she delivered at 30 weeks. Gestation. Okay, gestation means a period of pregnancy. She delivered twins born at 38 weeks of gestation. She also had a spontaneous abortion at 10 weeks, and she also delivered a daughter at 40 weeks gestation. So what we want to do is determine what her gravidity is. In other words,
4.
how did you come up with 4?
Because she delivered at 30 weeks. She had twins, but you don't count those. You just count it as one because it's one pregnancy. And then she had the abortion. That's 3. And then she got a daughter at 40 weeks. That's 4. She's pregnant 4 times.
Good, good. So how many of those then are considered terms? So we have T, term. So let's write down what her term deliveries are.
2.
Remember?
The twins and the
2
daughter.
of them.
And the daughter
Mhm.
says 2.
Mm-hmm.
Good. So just 2 pregnancies. We don't count the twins themselves because it's still the same pregnancy, right?
Mm-hmm.
Okay. All right. What about preterm babies? Babies born.
1.
So which one?
The 30-week one.
Stillbirth.
Abortion.
Okay,
Mm-mm,
the 30 weeks. The 30
30-week
weeks.
one.
Remember, abortions are before 20 weeks.
Mm-hmm.
Okay. And then how many abortions does she have
1.
1.
at 10 weeks? So then how many living children does she
3.
have?
3.
3.
So we have the stillbirth doesn't count. Okay. So we have 2 at 38 weeks and then the 40-week daughter. So she has 3 children. And that's how we do that.
Mm-hmm.
The stillbirth is still a delivery, even though the baby wasn't alive and it was during the preterm period. So we're going to count it as a pregnancy delivery, but it's not going to be counted in the living births or living children or live births. Let's do another one. A 44-year-old pregnant woman with 4 children, one born at 38 weeks, one at 39 weeks, and a set of twins at 36 weeks and an abortion at 7 weeks.
1.
5. 1, 2, 3, 4, 5.
4.
5. It's 5. She pregnant.
4
Five,
children and
still
she
pregnant.
that's 6.
1.
2,
1
3,
at 38
4,
weeks.
5.
3.
How you got 6?
5.
5.
She
I
pregnant.
got 6. I got 5. She
She
ain't,
pregnant
but
though.
she put 6.
3.
She's pregnant
She
now.
pregnant.
4.
So
Yeah,
that
she
would be
pregnant.
5, y'all. So
6.
one was
She's
born at
pregnant now, be
38
6.
weeks. One was born at 39. She got a set of twins. You only count that one time.
Yeah,
An
that's
abortion.
3.
That's
Abortion at
4.
7.
And then she's pregnant. That's 5.
Pregnant is 5.
And abortion, right?
Yes.
Yeah.
One born
But
at
she's
38.
But she got
One born at
6.
30, 7 twins. And she's pregnant. That's 5.
Yeah.
No, it's saying how many
It's
pregnancies, not
5.
children.
Yeah, because the
Mm-hmm.
twins are one set of pregnancy.
Right.
Mm-hmm.
Okay.
There
Keep
we go.
5.
That's right.
Everybody
That's right.
agree with that?
Yes.
Uh-huh.
Mm-hmm.
She's currently pregnant. She delivered at 38 weeks. That's 1. 39 a week. That's 2. Or sorry, 3. Set of twins. That's 4. And abortion. That's 5. Okay. So now, how many of those are term?
2.
1, 2, 3.
Two,
Two.
because remember she said
Two.
for term it had to be
37.
37 weeks or
Yeah,
more.
2.
So 2.
2.
Okay. Preterm.
1.
1.
1.
Which one?
The 36 weeks.
36 weeks.
36 weeks.
All right. And what about abortions?
1.
1.
1.
Yep, that's right. We can also say her GP status. We can refer to it as her GP status, gravidity and parity. So parity are the babies that are delivered after 20 weeks.
Mm.
Okay. So her gravidity is
4.
5, and her parity is what?
4.
3.
3.
Why is it
The
3?
abortion doesn't count in this one.
Oh, okay.
So it would be the baby's born after 20 weeks. So that just would be your term and your preterm babies. Gravidity 5, parity 3.
Mhm.
What's that?
Sorry, guys, that's my dog.
Oh.
Is it a cat?
Is your dog snoring?
He's a Frenchie, so they
Got a
snore all
Frenchie,
the
yeah.
time.
Oh, yeah. I had a Boston.
Sorry.
So we talked about carrier screening, right? So let's say James carrying a gene for cystic fibrosis or sickle cell, either one. Those are the two we look at in pregnancy because it's those two genes. If both mom and dad are carrying those genes, then we would expect James, if he had 4 children, that one of them would have cystic fibrosis or one would have sickle cell disease. Okay, that's what we call autosomal recessive. There's a 1 in 4 chance that the child will be diseased or will have a defective gene. But remember, both pair of genes have to be there. Both parents have to be carriers. And that's why it's called recessive, because it takes both of them to bring that gene forward. A dominant gene doesn't take both parents because that dominant gene will be pushed forward because it's dominant. And so half of the children have a risk of having the disease if it's dominant. Okay, so this list of disorders here: cystic, beta thalassemia, hemochromatosis, fetal ketonuria, Tay-Sachs, and galactosemia. Those are all recessive genes. So if there's a family history of PhD, which is phenylketonuria, which is a defect in metabolism, like galactosemia, it takes certain proteins and certain enzymes to break down certain foods, and we call it metabolic errors of metabolism, or just errors of metabolism. So that would be your PhD and your galactosemia, and those are also recessive. Galactose is a sugar in milk, and a baby that has galactosemia doesn't have the right enzyme to digest galactose, so they can't breastfeed. They have to have certain kind of milk. They have to have milk without galactose. PhD, these people have a very strict diet because phenylalanine are 2 amino acids that make a protein. phenylalanine is in meat, is in so much food. And people who have that disease should not be eating and consuming that kind of food because they'll have high phenol levels. And that can cause a neurological problem if they're pregnant in their fetus. It can damage the baby's brain. All right, Nagel's rule. We brought this up in our discussion, right? Start with the first day of the last menstrual period. Go back 3 months, add a day, add 7 days, and add a year. So if the first day of her last menstrual period was April 20th, 2024, what is her due date?
January 27th, 2025.
January 27th. Okay, so we went back 3 months and we added 7 days to the 20th, and then we have to add a year to 2024.
So 2025.
Yes. 25. Okay. What about February 22nd? Or sorry, February 2nd.
January.
Go back
November.
3 months.
November.
9th, 2026.
Mm-hmm.
November what?
9.
9.
2026.
2026.
Is it 2026? We're adding to February 2nd, 2025.
2025, because you're back in November of 2024, so it's
Right.
2025.
That's right. And okay, so if you make sure you understand this, if we go back 3 months, we're in 2024 at that point. And that's what we're adding. Okay, so let's do it this way. So February 2nd, and we're going to go back to 3 months, November 2nd, right? And then we're going to add 7 days, November 9th, and that's 2024. So we're going to add a year to 2024, so 2025. That's the progression. So make sure if it goes to the previous year that you add the year to that year, not the current year. What if our patient doesn't remember when their last period was? Or maybe they're irregular. She doesn't have one every 28 days. Sometimes it's 26, sometimes it's 29. What would we do? How would we estimate a due date?
Can you measure?
What would you measure?
Like the sac?
HCG
Okay, so
levels.
how would we do that?
Ultrasound?
You measure the fetus?
Yes, we can do an ultrasound. And we're going to measure actually the fetus. Because we're not going to we could do an embryo, but it would be very tiny. An embryo is done being an embryo at 8 weeks. At week 9, we have a fetus, okay? So if she's in her first 12 weeks, that's very accurate. So we measure crown to rump. So we do the ultrasound and we find the baby's head, the crown, and then the butt, which is the rump, and the ultrasound machine tells us how many centimeters that is. If it measures 9 centimeters, that means that baby's 9 weeks old, 9 weeks of gestation. That's very accurate. But so is Nagel's rule, pretty accurate. If we go into the second trimester, which starts at week 13, it's not as accurate. It might be off a week more later or earlier. And by the time you get to third trimester, it's off more. But we can measure bone length too, as long as we have a normal fetus. When you think about the physiological changes during pregnancy, what do you think when you think about cardiovascular system, respiratory system, immune system, the renal system, the skin? What do you think is the most significant? Endocrine system, GI system,
Cardiac.
all those systems. Cardiac, why?
The heart, breathing, it's respiratory. I would say the heart, cardiac, pulse.
I would say the heart because of the blood.
Because the blood volume, and yes, yes, it's significant and it's critical, right? Respiratory, the only change and as far as respiratory, she just takes deeper breaths. Okay, she doesn't breathe faster, just deeper. Now, as she gets really pregnant, very gravid, that baby is pushing up on her stomach. She's going to get a little bit of reflux and maybe acid indigestion. She might have trouble breathing when the baby pushes up on the diaphragm. So she might get a little short of breath. If she has cardiac issues or illness already, then she's certainly high risk. Okay. Why do we need progesterone and estrogen levels to really climb during pregnancy? We need estrogen. We need progesterone. So let's talk about what they do. Progesterone does a lot. It is our maintenance hormone. Progesterone is what makes the inner lining of the uterus, the endometrium, thick. In other words, a big bed of blood for when she conceives, that blastocyst can go inside that blood and plant itself to begin exchange. Okay, we need progesterone to have thick endometrium. It also does other things. It makes the cervix strong, so it contains the pregnancy. It does some skin changes. Okay, estrogen is our growth hormone. Okay, estrogen makes more red blood cells, helps red blood cells to grow, I should say. Estrogen will also relax blood vessels. Higher estrogen levels causes nasal congestion, maybe even nosebleeds. Estrogen also causes that increase vascularity of the pelvis to help feed our baby. Estrogen causes growth of the breast. They actually grow during pregnancy. They'll never be the same size after one pregnancy. The uterus, the same thing. Estrogen allows the uterus to grow. More uterine cells. Okay. So that's some of the basic needs of those hormones. So do you remember we talked about the changes in the blood during pregnancy? It causes a risk. One thing that causes a risk for blood clots during pregnancy is what? Do you remember? What goes on in the blood, in the components of the blood?
Getting more plasma.
Does it have anything to do with the red blood cells getting bigger?
Actually, it's the clotting factors. Remember I talked about fibrinogen and the clotting factors in the blood?
Yes.
There's more of them. Okay, so the volume of the quantity of clotting factors is greater. And then another thing is our red blood cells break down about every 120 days. Okay, we make new red blood cells all the time. The ability of plasminogen to break down those red blood cells is reduced. So she's got a lot of red blood cells, yes, and a lot of clotting factors. So she's at risk for blood clots in her legs, usually, her thighs or her calves. But she needs to know that, right? So we need to talk to her about ways that she can reduce the risk or mitigate that risk. So we want her to move around, get those muscles in her legs moving. Oh, I forgot to tell you that estrogen also causes, because of the increased blood volume and slowing of breakdown, varicose veins. Varicose veins are lazy, and they have trouble pumping blood forward back to the heart. So legs, even the vulva, the external surface of the vagina, the vulva can have varicosities, and they're very painful. It's like a congestion of blood. So blood clots. So we want her to move a lot. Okay, we don't want her to sit for long periods of time. High risk pregnancies, like people with blood coagulation disorders, they make more coagulation factors, or they have extra factors. Sometimes we give them Lovenox during pregnancy. They inject themselves once a day with 40 milligrams of Lovenox to prevent blood clots. Okay. Some diabetics, we might do that along with 81 milligram of aspirin, or just the aspirin. Aspirin is longer acting than Lovenox. Lovenox, you have to do it every 12 hours or every 24 hours. So sometimes a diabetic will be on an 81 milligram of aspirin during pregnancy, or a woman with lupus, because she also is at risk for blood clots. A patient that has a history of preeclampsia might be on a small dose of aspirin. GI changes. So I'll tell you one theory, and then you tell me what the two symptoms and signs of pregnancy. The GI motility, the movement, the peristalsis of the esophagus, stomach, and the intestine slows during pregnancy. So what kinds of things might our patient have trouble with during pregnancy if her GI peristalsis slows?
Constipation.
Constipation is one thing. What else?
Nausea.
Nausea, heartburn, reflux.
Like keeping food down.
Keeping food down, yeah. Okay. How can we help a woman that is having some nausea at the beginning of the pregnancy, the high HCG levels, the slowing of the GI? She might have some very uncomfortable nausea and vomiting. What are some things we can suggest other than giving her pharmacological options? What else can we do for her?
Ginger
tea. Well, however she wants to consume it, ginger will help. Ginger ale. What else?
Hydration
in the morning.
A snack before she gets out of bed, something dry and bland.
Saltine.
And what else did someone say?
Hydration.
We don't, sometimes drinking too much water can cause vomiting, believe it or not. So I recommend Coke or Pepsi products, preferably Coke products. Regular Coke, the syrup in the Coke and the carbonation tend to help reduce that feeling of nausea. So we want her to eat often, small meals, very bland. We're going to talk about a situation when we get to week 5 when someone has so much trouble with nausea and vomiting, they become severely dehydrated, lose weight, and their potassium plummets. So they need to be hospitalized for a while to rehydrate them. So small meals, we got lots of antiemetics we can give them. So we talked about the inner lining of the uterus. So the baby's connection, the umbilical cord is on the left side of this picture right here. You see that big umbilical vein carrying that oxygenated blood and all the nutrition to the baby going into the umbilical cord. Those vessels inside the umbilical cord are covered with Wharton's jelly. It's to keep them cushioned and moist and warm as it travels through that channel. Okay. On the right is mom's uterus. The endometrial vein and the endometrial artery are part of the uterus. And then the space in between is the placenta itself. We also call it the intervillous space. The blood coming from mom, the endometrial artery and vein, needs to be adequate volume and pressure, not too high, not too low. When it reaches the villus, intervillus, and it's coating the fetal vessels, the capillaries, you see there, they're like this. They don't mix, they're just up against one another so that oxygen and carbon dioxide can diffuse. They move from one vessel to the next, from a vein to an artery, artery to a vein. So that's diffusion. So the pressure inside that villus space is lower than outside, because the lower the pressure, the more exchange that can take place. Okay. The nutrients and the waste products and all other substances have to be moved across from one vessel to another or from one cell to another by energy, active transport. So you can see how critical it is for good oxygenated with nutrition blood getting to the umbilical vein for the fetus. So the placenta is considered the exchange organ, and it totally depends upon mom's blood pressure, blood volume for fetal well-being. People who smoke, we talked about it last week, don't get the best blood flow. Nicotine will reduce blood flow. Poor nutrition takes blood that doesn't have good nutrition. Adolescents, chronic hypertension, the blood flow isn't as good. I mean, it gets to the placenta, but then the pressure of that blood doesn't allow the pressure inside to be low enough for good exchange. Any questions about that? Here's just another depiction of how it's formed. You see the fetal villi right here. All these little trees are surrounded by maternal blood. And that's where the exchange takes place. We talked about the MSAFP, the alpha fetal protein. And we know that if the AFP is low in mom's blood or in the amniotic fluid, that there's a risk, an indication, I should say, an indication of potential Down syndrome or some other kind of trisomy, an extra chromosome. If it's too high, the neurological system has a defect in it. A potential indication there could be. AFP is high also if we have a twin pregnancy or multi-fetal pregnancy, like twins or triplets. It's going to be higher. Molar pregnancy is not a true pregnancy. There's no DNA in the conceptus. There's no DNA in it. So it doesn't survive. It overgrows. So what we usually see in molar pregnancy, low alpha fetal protein, because there's no fetal there. Okay. But the HCG levels are very high. Molar pregnancy is a high risk topic we talk about in week 5. So remember, if we have abnormal AFP levels, then we're going to do an ultrasound and perhaps an amniocentesis. I have a granddaughter with spina bifida. She is 19 now. She walks. She needs a cane, and she gets tired easily, but she is determined. She walks. And I remember when my daughter was about 18 weeks pregnant, and they did the AFP, and it was high. And then they did the ultrasound, which it's not diagnostic, but it's pretty accurate as to the Zoe having spina bifida. So we talk about growth restriction. In other words, the inability or the baby being inhibited in growth. Baby cannot grow as well from a certain factor. Intrauterine, inside the uterus, fetal growth restriction. So there's lots of causes. Poor nutrition, like I was saying about smoking. Blood pressure is too high. Sickle cell disease. If a woman has sickle cell disease, she might have a small baby. She's at risk for blood clots and a crisis during her pregnancy. She's anemic, okay, because her red blood cells, some of them have a sickle shape and they don't carry oxygen very well. And they don't have enough hemoglobin, and that's why they can't carry the oxygen, and they can't have enough good red blood cells, so they're anemic. Autoimmune disorder, we talked about lupus, and then alcohol. Your brain and your stomach will uptake alcohol before it will uptake into the blood glucose. The brain needs glucose. It's the only source of energy other than alcohol that there's a blood-brain barrier that will not allow protein in the brain, just glucose for energy, or alcohol. And alcohol is absorbed, metabolized a lot faster. That's why people who consume alcohol and they don't eat can really have trouble initially. They get real lightheaded. Very dangerous. So sometimes there is a disparity between a set of twins. It's called twin-to-twin transfusion, where one baby is so much larger than the other. And that's kind of beyond our discussion here. But I did want to show you that this can be caused by one placenta being shared by 2 babies. So there's not enough blood flow in one baby. One twin will steal the good blood. Okay. And there's other factors here that can cause restriction. You're not really required to know all these. Infections, if a baby has an infection during pregnancy, it can cause reduced growth. Or, a baby with Down syndrome baby is going to be smaller. There can be factors about the placenta itself. Poor placental development can reduce growth of baby. So when we think of IUGR, we think of women that smoke mainly and adolescents. Okay, this is just a video of placentation and fetal circulation. It talks about fetal blood flow. Remember that the blood going to the fetus has everything that the fetus needs in a normal situation. Got some chat questions here. Y'all can, let's see. Okay. Okay, Angela. You can interrupt me. Okay. I know you don't want to just announce that you have to go to the bathroom, but okay. So you can watch that. It's not very long. You can watch it to help you understand fetal circulation. Fetal circulation, let me go back up here. And it's not in this PowerPoint, at least I don't remember putting it in here. We have shunts. The fetus has shunts to direct the blood toward the body, not towards the lungs. The lungs are not functional during fetal life because the blood is already oxygenated. They don't need to function. So there's a shunt that doesn't allow as much blood flow to the lungs of the baby, of the fetus. Okay. So it's shunted away from the lung. That's the major one. There's also a shunt because of that, there's a shunt between the right and left, not a shunt, but an opening between the right and left atria. So as you're reviewing this term in MedSurg, if you're in MedSurg 1, the heart, you'll know that there's two atrium, right? Two atria, 1, 2. And there's a hole. It's called the foramen ovale. And the blood that comes in from the vena cavas goes to the left atrium and it bypasses the right ventricle because we don't need it to go to the pulmonary artery in the lungs. Okay. But you can look at those pictures and watch the video. Sometimes that helps. And we talked about supine hypotension, where we have a big baby, right? And if mom is lying flat on her back, she could compress that vena cava. Remember, veins are not muscles, and they can be easily compressed. Arteries are muscles. They can stretch, they're elastic, they can constrict. So the aorta that's right along with that inferior vena cava is going to stay normal size. It's not going to be compressed. Not as much. Okay. So if she starts feeling lightheaded, nauseous, or the baby's heart rate drops, we got to get her off of her back. So we're going to roll her to her left side because the vena cava tends to run more on the right side of the vertebrae. Just roll her to her left side. Sometimes we do it the other way. If the left side doesn't work, we're going to roll her to the other side, or maybe up on her hands and knees to try to improve blood flow to the placenta. Okay, so I answered all the questions and we talked about it. So it reduces blood flow to the brain and the uterus and reduces fetal blood flow and fetal heart rate. What's your priority? Reposition the mother. Reposition the mother. That's always the answer. If you see a baby's heart rate drop, or if you're assessing a woman at 28 or let's say 32 weeks and she's lying flat and you've got a Doppler on there and the baby's heart rate's below 110, you're going to get her off of her back, roll her over. She might be lightheaded if you try to sit her up. Okay? That's supine hypotension or aorta caval syndrome. Same thing. What is the term used to describe the inability of the fetus to thrive and grow? Remember what we said it was? What prevents? What's going on? What do we call it when a baby has trouble growing? If you're trying to say
thrive?
Yes, failure to thrive.
failure to thrive is usually a newborn.
Okay.
Okay.
Internally, it's called what? Starts with an I.
IGHR.
IUG, IUGR. Yeah, intrauterine growth restriction. So the earliest we can palpate a growing uterus with a fetus in size is about 12 weeks. It's just at the level or just above the pubic bone. Just above the pubic bone, 12, 14 weeks. We should be able to put our hand down there and be able to palpate and feel that uterus. At that time of her gestation, the uterus is getting large enough that it's coming up out of the pelvic cavity. It becomes an abdominal organ as it progresses. So about 20 weeks or so, it should be at the belly button. So you should be able to feel the uterus, and we call it the fundus, the top of the uterus. We should be able to palpate it about at the belly button at about 20 weeks, the umbilicus. So if you have a teenage mom, it might not be there yet, or she smokes. Her fundus might not have reached 20 weeks. Or maybe her fundus is only at 28 weeks when she's 32 weeks pregnant. Small babies. So lightning is a term that you'll in particular, we will talk about in week 3 when we're talking about labor and delivery. Lightning is when she reaches closer to 36 or 38 weeks, especially if it's a new mother. Once she reaches 40 weeks, that fundus might drop down a little bit because the whole baby is dropping down into her pelvis now, getting ready for labor and delivery. It's called lightning. So it drops down, and I try to tell students, remember it's called lightning because lightning drops down out of the sky, right? It doesn't really drop, it strikes. But it helps remember. Okay. Folic acid. Do you know folic acid is called our growth vitamin? It's vitamin B9. Vitamin B9 is necessary for fetal growth. If mom does not consume enough food with vitamin B9 during those first 8 weeks of her pregnancy, called embryology or organogenesis, when all the organs are being developed, the heart, the lungs, and the brain, the neurological system. If there's not enough folic acid, she's not taking prenatal vitamins, then they can have what we call neural tube defects, like spina bifida. Spina bifida isn't always caused by deficient folic acid intake. There's other things that can also cause it. So your vitamin B9 foods are citrus, legumes, green leafies, things like that. All of my favorite stuff. So here is the fetal heart surgery. This really needs to go up higher, doesn't it? Oh well. So remember, we need blood to come into the fetal, into the through the umbilical cord and it starts to circulate and travel around the liver. It's not going to give the liver much blood. The liver's not really functioning that much during fetal life. Mom's liver is doing a lot of the filtering. And then from the liver, it goes to the vena cava. From the vena cava, it goes to the right atrium and then the left atrium. The majority of the blood goes to the left atrium, not the right ventricle. Some blood is going there. Some blood is going to the right or to the pulmonary artery. But the pulmonary artery is not really circulating much of the lungs. So once the baby is born, the left and right, because of the pressure change at delivery, there's greater pressure in the left atrium. So it closes up the foramen ovale, that opening between the atria, because the pressure change, the blood pressure of the baby increases after delivery. And the pressure change within the heart allows the lungs to be perfused at that time, right after delivery. And we talk about that later. It's an amazing thing. So when would the fetus be in danger of compromise? I don't know why this is in here. I need to get rid of this. Don't know what I was asking. So a fetus practices breathes. They swallow the amniotic fluid during fetal life. We have to have an adequate amount of amniotic fluid for the baby to grow and to maintain temperature of the amniotic sac to keep the baby at a good ambient temperature. That's about all it does. The amniotic fluid doesn't have a whole lot of functions, but they're very important. So if we have an adolescent and she's high risk, or if we have a diabetic and she's high risk, or sickle cell, lupus, some kind of autoimmune disease, or maybe kidney disease or heart disease, they're higher risk patients. So the farther they get into the pregnancy, the closer eye we have to keep on them, not only the mother, but in particular the baby. So we do particular testing, client education to help them. Ideally, we want them to plan pregnancies so we can put them in the most optimal health before they conceive. Watching them closely during the pregnancy, during labor and delivery, and good postpartum follow-up for at least a year. Remember, it's the postpartum where we see a lot of the mortality rates that go up. So during late second and early third and later on, we're going to teach mom about being aware of baby movement. We want the baby we want her to feel her baby kick or move 10 times every hour or 2. We can do non-stress tests on babies that don't seem to be growing well. We can do an ultrasound that's called a BPP. It's a targeted ultrasound. We're looking for 4 criteria. So the targeted ultrasound called the BPP, you don't have to know specifically exactly what we're looking for, but you know that there's like 4 or 5 criteria and we score it. If we see that the baby has good muscle tone, movement, good reflex activity, maybe sucking their thumb, swallowing amniotic fluid, that's practice breathing, and good amniotic fluid volume, then we would give them a score of 8. If we do a non-stress test along with that, we're going to give us, and it was normal, we're going to give 2 more points, so 10. So we would want 10 out of 10 points. If we were able to see all these and it was a good non-stress test, we know our baby is thriving, doing well. But if we have a baby that's not growing and it's at the low, very low percentile, and we're not seeing a whole lot of practice breathing, or maybe the amniotic fluid volume is very low, then that baby's not thriving and could die. It's compromised. So sometimes it's indicated that we deliver a baby early if it's not growing. If this babies are less than the 10th percentile, we consider seriously delivering early, even before full term. Be better to have a preterm baby than a dead baby. So we can do a BPP. We can do the non-stress test. This is simply putting a monitor on baby and looking at the baby's heart rate. She's not in labor. We're just watching the baby's heart rate go up. So mom has a button in her hand. Every time she feels the baby move, she presses a button. And movement should result in an increase in baby's heart rate. You see all the bumps above? Those are accelerations. And they correlate with the marks at the bottom where she feels baby moving. Every time that baby moved, the heart rate went up. That is a really good sign. It means a baby has adequate oxygen and is able to adjust, has enough energy and oxygen to move, and the heart rate is able to go up. So we want a positive non-stress test. Positively, that baby's heart rate went up. So we want to see it 15 beats a minute increase in the rate for a 15-second period for at least 15 beats. In other words, 15 different beats, if it makes sense. We want to see all this happening within a 30-minute period, 20 to 30-minute period. So the non-stress we want it to be positive because it's showing good oxygenation. That's all you really have to know. The contraction stress test is we want to see what happens to our baby if mom has a contraction. In other words, is it going to be safe for our fetus to go into labor? Is the baby going to be able to tolerate labor? If we have a small baby and if we don't test the baby, then what we might see is during a contraction, the heart rate drop. There's not adequate blood flow to the baby and the heart rate drops. We call it contraction stress. And what we do is we give her some oxytocin to cause a contraction. And in this picture, you see that the results are positive in that, yes, the heart rate did drop. We don't want a positive. We want a negative result on this one. It's the opposite because we don't want to see any deceleration. So we're measuring decelerations for the contraction stress test, whereas the non-stress test, we're measuring and looking for accelerations. That's the difference between the two. We do not want to see decelerations. In other words, a baby cannot tolerate that uterus being squeezed. Okay, so this is just a pictorial of all the different physiological system changes during pregnancy. So you can kind of just look at this and refresh yourself. We didn't talk about weight gain and all that stuff. So weight gain, 25 to 35 pounds. 1 to 4 pounds during the first trimester. And then about a pound a week after that. Y'all know that hemorrhoids are also varicosities. Hemorrhoids are, they're blood vessels, veins that are engorged. And sometimes we see that during pregnancy. All right. A very hard concept to understand, and it takes some time, is blood type incompatibility, Rh discrepancy, or not discrepancy, but interference in the antibiotic system, in the immunoglobulin system. Okay. So if a mother, plainly put, if a mother is Rh negative, if she is A negative, B negative, AB negative, O negative, then she needs an immunoglobulin D during her pregnancy or after delivery to prevent her body from making antibodies against her Rh positive fetus. Let's put it very plainly. Okay. So every woman with Rh negative blood needs RhoGAM. We always assume the baby is Rh positive. So if she has an abortion, she will need RhoGAM. So protect her next baby that she gets pregnant with. If she has an ectopic pregnancy, she needs it. We routinely give it at 28 weeks. If there's any trauma or any question about mixing of the blood, remember the blood doesn't mix. And if it does, and mom doesn't have that D antigen, baby has it. So this is going to be very aggressive in trying to destroy the next baby. Okay. And then after she delivers her baby, before she goes home, we'll give her a shot of RhoGAM. It's temporary. It's only good for 12 weeks, but it prevents her immune system from developing an anti-D antibody. This is a video that you can watch. Video, when there's a hard concept, videos are sometimes the best way to learn it. Okay. Let's see here. So make sure you get your sim chart done first this week. When you sit down to work on your homework for OB, do your sim chart, okay? And then do your discussion. Anybody having trouble with their schedule as far as plugging in time when you're going to prepare for your classes? You know when your clinicals are, or simulations, all that stuff? Did you plug in your schedule? It really helps. It really helps. It'll give you a little peace of mind so that you can focus if you study. I don't know what you have tomorrow, Thursday. A lot of you might be free in the morning. I'm not sure what your schedule is. So you might decide, I'm going to spend 3 hours on med-surg. I'm going to study for an hour, take a 15-minute break, study for an hour, however you do it. And just focus on med-surg that day. If you want to work on OB that day after attending class and you realize you really need to brush up on this stuff a little better, then do OB. Erica, what did you ask? Somebody asked me a question.
I did. Like when we go to med-surg clinicals, we have paperwork that we have to turn in. Do we need to turn that in to you, like scan it or take? No? Okay.
No, I don't, I'm not involved in grading or evaluation of your clinical work or your simulations. Those people are on campus and they do that. And yeah, you probably have to do OB preparation to go to clinicals. Okay. That's a good question. Anything else? If you didn't do your, yes.
One question. Do you know how long it'll be before you post this lecture?
I'll do it tonight.
Okay.
Yeah, I usually try to post it tonight.
Okay.
And the same night. Yeah.
Professor Zeller.
Yes.
So you said do the sim chart before our discussion, but our initial post for the discussion is due before 11.
That's true. Wednesday. Yeah, it's due tonight, actually.
Okay.
So the 3 post is our initial and then 2 replies.
Actually, you only need 2 replies. So you could do your initial tonight and reply to another student who's already posted. And then just 1 other reply.
Okay.
You don't have to. Just do your own and then worry about the other 2 later.
But we can do the other 2 in one day, like we don't have to do them in separate days.
If you do your initial tonight and then choose to do the other 2 posts on a day, you can do them on the same day.
Okay.
They have to be 2 separate days. All of them have to be on 2 separate days, whether you want to do 1 and 1, 1 and 2, doesn't matter, or 1, 1, 1. Okay? Just 2 separate days. All right. Let's see here. Anything else? Miss Rosa, did I answer your question? Where are you?
I'm still typing it. Sorry.
Oh, okay. All right. Well, the rest of you, if you don't have any questions, you can sign off.
Have a good day. Night.
You too. Have a good night.
Thank you,
guys.
Try to come Sunday
Bye.
night.
Bye,
Try to come Sunday
everyone.
night. We're going to do a case study Sunday night.
Oh, cool. 7:30.
Yes.